on this computer, share screen, share, and I will do. Okay, can you see now? Can you see my screen?
Yes, sir. Yes, sir.
Okay, Nikhil. So 25-year-old chap presents to A&E with a history of hemoptysis. Has had sudden onset hemoptysis, 3 episodes, each one of 100 ml fresh blood. What do you want to do?
Since still I like to ask further question. Since when is he dyspneic?
Yeah, intermittent, little bit.
At present he is he okay.
Little bit. He's more scared than dyspneic.
Is more scared than dyspneic. So basically it's a stable condition.
Yeah,
So,
he's stable.
uh, so the hemoptysis, the blood is red color, fresh red color.
That's what he says.
Oh, 3 episodes. And since when he is having?
Yesterday afternoon.
Yesterday afternoon. Was it associated with clots or?
No, fresh blood, he said.
Okay, it's not not associated with cough. Is there any chest pain?
No chest pain.
No chest pain. No breathing difficulty. Intermittent breathing difficulty.
Yeah, I mean, he's all right. He's more scared than anything else.
Okay. Did you get vomiting sensation before the blood?
No.
No. It's just when you cough it out, that time you.
Yeah, first episode, he just coughed. He suddenly found blood.
Blood. No chest pain. Is there any fever?
Any what?
Fever.
Yeah, he's been having a bit of fever, particularly in the evening, late evenings, over the last few days. Last couple of months, he's just been a little bit under the weather.
Okay. Is there any, is it associated with sweating?
No sweating, no.
No sweating.
Just general low-grade fever in the evening. He's been feeling that something is not well for the last couple of months, but suddenly he's had this episode today.
Did you lost weight or decreased?
Yes, he feels his appetite has gone down, and he does feel that he may have lost some weight.
Okay. Is there any? Are you taking any blood thinners?
No, he's 25 years old. He's a young guy.
Or no major? Have you ever been suffered from tuberculosis in the past, or is there any family having active tuberculosis?
No. No family history of tuberculosis.
No family history. Is there any intervention is done for? Did you show it to someone else? I mean, a general practitioner also?
First episode, he's just presented to A&E. 3 episodes in the last 24 hours, little bit of fever and little bit of malaise and mild weight loss, but nothing significant. So how do you describe this? What is the level of this cough? Is it mild, moderate, hemoptysis? Is it mild, moderate or severe?
It's moderate hemoptysis.
Okay. How do you classify hemoptysis on the quantity?
Sir, more than 600 ml 600 ml 24 hours is a massive hemoptysis.
What is mild? What is moderate?
So exactly.
You told me it's moderate. Why do you say it's moderate?
It's less than 600 ml.
Less than 600, but it could be mild.
What's
the difference between mild and moderate? Anybody else wants to take this question? What's the difference between mild and moderate hemoptysis? Hello? Raza, you want to take it? Can you hear me? Just say yes or no, it's okay. No. Nikhil, nobody's helping you, man.
Sir, less than 100 ml is mild.
Okay, so less than 30 ml is mild, okay? Less than 30 ml is mild. 30 to 50 ml is over 24 hours is moderate. And more than 600 ml is severe, okay? What is exsanguinating? There's one more term, exsanguinating. What is exsanguinating? What is the number for exsanguinating?
More than 1,500.
No, it's more than 150 ml per episode, or more than 150 ml per hour, or 300 to 400 ml per episode. That's exsanguinating. How much blood is needed to upset your breathing, air exchange?
More than 150 ml, sir.
Yeah, so around 150 ml is enough to cause loss of air exchange. Okay, I can see that Soumya has joined us and a few more have joined us. So I think, Nikhil, we'll just stop 2 minutes for this case. And I want some feedback from these guys because that was the first thing I want to do. I think Ali Hanif has also joined us. So Soumya, do you want to give us some feedback on how the FRCS part 1 was? Yeah, you did give us a detailed feedback, but we would like to hear from you. Are you with us? Is it possible for you to talk, or you are not in a position to talk? Hello? Nikhil, can you hear me?
Yes, sir, I can hear you.
Okay, I think she may not.
So actually, Soumya is still connecting. I think unstable network.
Oh,
She is not yet connected.
Okay, all right. So continue with the case. So what is common etiology of hemoptysis? When a patient presents with hemoptysis, what are the common etiologies? Give me as many as you can think of, okay? I want more people to participate. So whoever else wants to participate can participate.
So, infective etiology, tuberculosis.
Yeah, okay, good.
Malignant, the aspergilloma.
Okay, good.
Then
you said something before that. Blood is always not a good sign, no?
Yes, sir.
If you get blood, what do you think? One is infection. I completely agree with you.
One is malignancy.
Yeah, why are you scared of saying malignancy? Okay, good, malignancy. What else? In infection, besides tuberculosis, chronic infection. What about acute infection?
So pneumonia.
Yeah, very good. What else? Anything else that can cause acute infection?
Trauma.
No, acute infection.
Acute infection. Klebsiella pneumonia. That is a pneumonia.
Pneumonia we got. What else? What will cause necrosis in the lung and
lung
erode?
Abscesses.
Yeah, lung abscess. Very good, very good. These are common causes. The first 4. These are top 4 causes of hemoptysis. Okay, remember this in the exam. Whenever somebody asks you, you should say tuberculosis, lung cancer, pneumonia, pulmonary abscess. Okay. Besides that, you told me aspergilloma. What else? Chronic diseases, chronic medical diseases. Anything you want to name?
So cardiac, like
no, lung disease first.
Interstitial lung disease.
So what is the common interstitial lung disease that can cause hemoptysis? Cystic fibrosis.
Cystic fibrosis.
More common than cystic fibrosis. What causes hemoptysis, which you see in your clinical practice? Smoking related disease or something like that.
COPD.
COPD, but more specific.
Bronchiectasis.
Bronchiectasis. Well done. Bronchiectasis. Well done. What else? Other causes? Inflammatory causes?
Bronchitis.
No, bronchitis. Tell me more things. We have done bronchiectasis, bronchitis done. Tell me other causes. Other fungus that can cause?
Other fungus?
Mycetomas, sir.
Yeah, better than
Histoplasmosis.
mycetoma.
Histoplasmosis.
Histoplasmosis is correct. More common than that. Mucormycosis. Okay. Mucormycosis, sarcoidosis, septic emboli. Okay. What else? Anything else you can think of?
Sir, good pastures and Wagner's granulomatosis.
Yeah. Any vascular disease can cause. Vasculitis can cause. Yeah.
Pulmonary embolism.
Pulmonary embolism can cause hemoptysis. What about any cysts or something? Infective cysts? You know of any infective cysts which can cause compression
Hydrated.
hydrated. You're absolutely right. Hydrated. And then what else? Congenital is pulmonary sequestration. You told me interstitial lung disease. I agree with you. Bronchiolithiasis, mitral stenosis, trauma, coagulopathy. Don't forget coagulopathy. Okay. All right.
Yes, sir.
What about iatrogenic hemoptysis? What are the common causes for iatrogenic hemoptysis?
Sir, previous endobronchial therapy or bronchoscopy.
Bronchoscopy can cause. Yeah. What else? ICU, you get called for hemoptysis a few times.
Sir, intubation.
Intubation, but more importantly, after intubation, what is the long-term ICU patient to whom you commonly get called to do a bronchoscopy?
Tracheoinnominate fistula.
Tracheoinnominate fistula, but before a tracheoinnominate fistula, what is even more common? Tracheoinnominate is very rare. I agree with you, that is, you will get called, but commonly in an ICU chronic patient on long-term ventilatory support, what is the commonest thing in an ICU that causes iatrogenic?
Ventilator-associated pneumonia.
Tracheostomy.
Tracheostomy, absolutely right, okay? Absolutely right, tracheostomy. And then tracheostomy can cause a tracheoinnominate fistula, okay? Or a stent can cause and then others are more rare is PA catheter injury, okay? While they're doing any PA catheter. Other things that can cause hemoptysis? Post-bronchoscopy, you said, okay? But why in bronchoscopy? Particularly when they've done a biopsy, that's more common, okay? Yes. How about a radiologist calling you for hemoptysis? Common?
Stenting.
No, more than stenting.
Bronchial artery embolization.
More commoner than that.
Biopsy, image.
Yeah, biopsy, percutaneous biopsy, yeah. Percutaneous biopsy and transbronchial biopsy. Okay. Tell me a little bit about bronchovascular fistula. What do you know about bronchovascular fistula? Where do you see it? It can present with sudden hemoptysis.
Mostly after pneumonectomy.
Yeah, after pneumonectomy, after sleeve resections. Yeah. Okay. So commonly what happens is there's anastomotic insufficiency and infection. As a result of that, so if it's after bronchovascular sleeve resection, then you might have to go in and do a completion pneumonectomy, okay? And then if you're doing lung transplant, then in lung transplant, you might see a aortobronchial fistula. Can be seen sometimes, or, subclavian artery eroding through there. And lastly is aortic aneurysm eroding into. So these are a few types of bronchovascular fistulas. The reason why I brought this up, it's a bit late now, but this actually comes up in one of the MCQs. This was there, so I just brought it up for you guys to say. Where do you see bronchial artery aneurysms? Anybody can come in. Where do you see bronchial artery aneurysms, which can also cause hemoptysis? Hello?
Yes, sir.
Bronchial artery aneurysm, where do you see? Common. What disease?
Tuberculosis.
Bronchiectasis.
Sir, superior vena cava obstruction.
SVC obstruction causing reverse flow. Yeah, it is possible. I'm not saying no to that. But common is bronchiectasis.
Sir, lung cancers and...
Yeah, we did cancers right at the start.
Sir, syndrome is the Osler-Rendu
Excellent. Osler-Weber-Rendu syndrome, where you get AVMs, okay? And AVMs can be mediastinal and intrapulmonary. Okay. What are the common syndromes which cause hemoptysis? Again, this is a MCQ, by the way. It's a bit late for you guys, but just to tell me the syndromes in which present with hemoptysis.
Sir, one is Osler-Weber,
Yeah,
Yeah,
Osler-Weber. Okay. Anything else?
and other is Wegener syndrome.
Wegener syndrome. Okay, agreed. What else?
Bronchiectasis.
What are the other syndromes that you know of? Bronchiectasis is part of what syndrome? You have to give me a name. This question is about syndromes.
Sir, it is Carter-Negrove, sir.
Cartigenous. Okay, yeah, that can cause. Behçet's disease, Hughes-Stevens, Takayasu's, which is arteritis, Eisenmenger's can cause, and Wegener's granulomatosis. This is again an MCQ, by the way. This slide was made from an MCQ from the FRCS questions. So of course it didn't come this time, but just for you guys in future, if you ever want to remember this slide. These are the syndromes which are can commonly present with hemoptysis as a prime pathology. Yeah, okay. All right, so you have got this guy with hemoptysis. How are you going to investigate this guy?
Sir, I like to do a chest X-ray.
But before that, tell me how will it differentiate? What are the differential diagnoses of hemoptysis?
So one is the hematemesis.
Good, hematemesis. I like that. What else?
Sir, pseudohemoptysis.
Excellent. Pseudohemoptysis. What else?
Iatrogenic.
Any ENT bleed, sir.
ENT bleed. Excellent. ENT bleed.
Epistaxis.
Well done. Epistaxis. Yeah, these are the common. You must keep these in mind whenever. So all blood may not be coming from the respiratory tree. So now my question to you, Nikhil, is in this 26-year-old patient, how do you know this is hemoptysis and not, this is hematemesis or hemoptysis?
Sir, he doesn't give any history of vomiting. I didn't ask about the GI symptoms.
Okay.
Like epigastric
So he
pain.
gave no history of upper GI disease. Okay, that's fine. He said no history of vomiting. I agree with you. What else? What is the pH of hematemesis and a pH of hemoptysis?
Hematemesis is acidic pH.
Yeah, hematemesis is usually acidic pH. So if you dip in your, what do you call it, litmus paper, it will show you it is acidic. Good. What else? Two more factors. How can you tell hematemesis from hemoptysis?
Sir, in hematemesis,
color. What is the difference?
Color.
What is the difference?
Sir, it may be in hematemesis, it is mixed with the food content or bile.
So color would be a coffee ground appearance in hematemesis,
Okay,
and
coffee ground appearance or dark
and
red.
clotted appearance in hemoptysis.
Hemoptysis can be bright red. If it is fresh hemoptysis, it could be bright red, isn't it? So that's the one. One more thing. What else? Foaming. Anything? Any difference in the foaming?
Sir, the hemoptysis would be a frothy.
There is frothy.
Yeah, hemoptysis is usually frothy. Okay. So hemoptysis is usually frothy, whereas hematemesis is just projectile or just comes out and there is no froth with that. Okay, so this is the difference. Remember this this slide. Okay, this is a common question we ask in the long case, particularly when I'm doing a long case with a candidate. I will ask him, "How do you know it's not hematemesis?" Yeah. So you must know the difference between the two. All right. Okay.
Yes,
How are you going to investigate this guy? Besides clinical examination and all that, we've done that. I am okay with that. Now tell me, how are you going to investigate this guy?
Sir, is there any previous chest X-ray available? Or if not, then
no, we don't have any previous chest X-ray available.
So I like to have a chest X-ray view if the patient is stable. Or
so what do you expect to see on a chest X-ray?
Sir, in a chest X-ray, I expect to see is there any cavity or any calcification, not calcification, but pneumonia. Is there any mnemonic changes? Any mass lesion? Any
What if I tell you that a patient with hemoptysis had a normal chest X-ray? Is that ever possible?
possible, sir?
So what percentage of patients will have a normal chest X-ray?
So 10%.
Actually, around 40%. By the way, just to let everybody know, because people who joined late, that we are doing a case presentation today because Dr. Vikas, who was supposed to do carotid endarterectomy today, has got caught up in theater. Okay, he's still stuck in theater. So he sent a message that he's unable to take carotid endarterectomy. So please don't be disappointed by seeing me doing some teaching. It's just I'm stepping in because Vikas is still stuck in theater. Okay, so I hope it's all right with you to do some cases. All right. So commonly 60 to 80% you will see some pathology. What is the commonest thing you will see, man, in a chest X-ray? Besides the pathology, what is the other thing you see?
So the heart.
Lungs, mein, what do you see in the lungs? When blood is present in the lungs, what do you see on a chest X-ray? What is the word I'm looking for?
Infiltrates.
Infiltration. Very good. Please use the correct word. Okay. So the word is infiltration. Yeah, when blood is present in the lungs, or if the patient aspirated or anything, what you see is called as infiltrates. So pulmonary infiltration is the word that I want you to use in the exam, because that is the right word to describe this view. Okay, what else will you see? You will see cavity, you will see anything else, whatever is the pathology you will see. So this guy went on to have a chest X-ray. Okay, this is not a chest X-ray which I'm just showing you, but it is just a vertical section of his CT scan. So this is what was found on his chest X-ray. So what do you think, Nikhil?
This is a cavity in the right lung. Well circumscribed, well defined, but
what do you want to do with this patient? What do you want to do with this patient? Next step, quickly.
Sir, CCT chest.
Yeah, but before that, do you want to do any routine investigations?
Yes, sir, I like to do a routine investigation.
What
CBC,
routine investigations? Yeah, okay.
CBC, LFT with PTI.
Along with CBC, anything else you want to do?
Sir, creatinine.
Arey Baba, with CBC, what else you want to do?
Hemoglobin.
ESR.
ESR, thank you.
Yes.
CBC and ESR, okay. What else? Why ESR, Nikhil?
So to see for
chronic infections.
Chronic inflammations, correct. Chronic infections, chronic inflammations, okay. All right, and also to get a baseline ESR, yeah, so that you can track him in the future. Okay. What else? Quickly tell me the blood investigation.
RFT.
Nikhil. 1 second.
RF,
yeah, okay.
liver function test with
Yeah, yeah, with coagulation. Very good. Coagulation profile is very important. Yeah. What else? Why do you want to do RFT? 26-year-old guy. Why do you want to do RFT?
Sir, for a CCT chest.
Ah, excellent. So you're going to be giving contrast to the guy. Okay. So he went on to have a CT scan, and this is a section of the CT scan. Do you want to describe what you're seeing?
Yes, sir. There is a cavity in the right lung.
Are you talking or you're not talking? Is your voice getting cut off or are you stopping and talking? Because this is a straightforward CT scan. You should go bang, 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 bang in the exam. You shouldn't even waste 30 seconds on this CT scan, okay? So quickly
Yes, sir.
describe to me what's happening.
Sir, this is the hydrated. This is the cavity filled with fungal ball with the materials.
First describe the damn thing and then give differential diagnosis. Nah, Nikhil.
Sir,
You on one side you said hydrated, on the other side you said fungal ball. You just describe what you're seeing in front of you.
sir, this is the CT scan chest lung window.
Thank you. Go ahead.
Showing the cavitatory lesion in the right lung.
Yeah.
The cavity is filled with a mass.
Yeah.
And the rest of the cavity with the air.
What about the wall of the cavity?
It's a thick wall, sir.
Yeah, so I can see a thick-walled cavity with some stuff within the cavity. Okay, I mean you have to describe this, no? What level is this? How will you know the level if I show you just one section?
Aorta and the sir, I cannot see the. This is the right lower lobe, sir.
Yeah, it is in the right lower zone because you can see right and left ventricle, no? So
Yes,
right
sir.
and left, it's a lower cut. If you see aorta and things, it is in the upper lobe. So you must correlate the other structures, okay? Even if I show you one snapshot. And one important thing that you have to always look for is the tip of the scapula. Can you see? Can you see the
Yes,
tip
sir.
of the scapula or no? So tip of the scapula is what level?
So
Tip of scapula corresponds with what intercostal space?
the fourth.
Maybe fifth or sixth intercostal
Fifth or-
space. So we do a thoracotomy there, no? Always 1 centimeter
Yes, sir.
below. So if this is around the fifth or sixth intercostal space, so it's more likely to be in the lower lobe. Okay. All right.
Yes,
Now
sir.
tell me what is happening on the right side, on the contralateral side.
Sir, there is a infiltrative changes.
In the contralateral side. Why do you think this is?
This is because of the hemoptysis. There is a spillover.
So there could be aspiration with hemoptysis.
Aspiration.
Okay. And what else? What is the other answer you will give for that? One is there is aspiration of the blood. I agree with you. What else could it be?
It could be a diffuse aspergillosis.
Yeah, use the word, no? Aspergillosis. This could be fungal. You don't know that. There could be fungal on the other side, no? We don't know that. Okay. All right. Good. Now, let's come to, you've done the CT scan. What's your management in this guy? What other investigations can you do? Let's finish the investigation, then we'll talk about management. Any other investigations you want to do?
No, sir.
All right.
Sir, so seems to be aspergilloma, first episode.
He's got a hemoptysis, no? Anything you want to do for this guy or no?
Bronchoscopy.
Yeah, you want to do bronchoscopy in this guy, no? Obviously, you will do bronchoscopy, correct?
Bronchoscopy. Yes, sir.
Because if you've got left-sided this infiltration, I just show you, where is that CT? Okay, there's left-sided infiltration. There is right-sided lesion. So how do you know where the bleeding is coming from?
To localize and lateralize.
Yeah, so you need to know where the bleeding is coming from. So you will line this up for bronchoscopy. Okay, bronchoscopy, I'm okay with that. Anything else on CT that you want to do?
Bronchial artery mapping.
Sir, CT angiogram.
Yeah, CT angiogram you would like to do, isn't it? You'd like to do a CT angiogram just to know the site of bleeding. Yeah, most important thing is you want to know the site of bleeding. So once you know the site of bleeding, then you can confirm it with bronchoscopy. If you can't see it on a CT, you can confirm with a bronchoscopy. If you can see it, then there is a scope for treating the thing at the time of the CT angiogram, isn't it? Or on a second stage sitting. Okay, so this is the pathway for CT angiography. Okay, So it's quite important to know that the next step in your investigation should mention CT angiography. Okay, all right.
Yes, sir.
And in addition to CT angiography, what else will you do? The CT angiography has been done. What can you do?
Bronchial artery mapping.
How do you do bronchial artery mapping? What is the technique called as?
Bronchial artery angiography.
No. You've done the CT angiogram. What do you do on the computer? And you look for the blood vessels. What is it called as?
3D.
3D reconstruction.
Sir, extravasation of dye.
Yeah. So you look for 3D reconstruction. You actually reconstruct the whole thing, artery, and then you look for 3D reconstruction, and then you try to find wherever the dye is extravasating. It will very clearly show you what is the site of your this thing. Okay, so now I am going to come back. So far, so good. Are you clear? I'm trying not to go into too much depth. Just stay superficial, but understand the philosophy of management. Yeah. Are you okay so far, so good? Yes or no?
Yes, sir.
Okay, so
Yes,
now
sir.
you've got this guy. How are you going to manage? You're called in the A&E. You've asked for CT, VT, everything. But before all asking for CT, how do you manage a guy who presents with hemoptysis or with bleed?
Sir, oxygen support, bed rest, Fowler's position, IV cannula,
Yeah, good.
blood while I putting IV cannula, blood for cross match and routine investigation.
Okay, good. I like that.
And then
So you have to stabilize the guy before you rush him into the CT scanner. Okay, you have to make sure that the patient is stable. Okay, so I'm completely agreeable with you that you put in two large bore cannulas. You hydrate the guy, take bloods for investigations, keep blood cross match ready. Why do you want to do all this?
sir, blood fluid for loss which
Yeah,
has,
but why do you want to do all this? Why do you want large bore cannula and everything ready? Why?
because if he has a hemoptysis, he can rebleed.
Absolutely, because the patient may rebleed. Okay, that is the real main thing. Okay, so that's why you have to do everything before. Yeah. Sorry, somebody was saying something. Who's saying something? Ankit, you're saying something? Go ahead and say it. Did you make a comment? I just heard somebody's voice. I don't know what it was. Okay. So the guy has got mild hemoptysis. How are you going to treat?
Sir,
We've established that he's got mild hemoptysis. And you've done the investigation. Nothing specific come up. The CT scan showed some changes. But how are you going to treat if this guy had only mild hemoptysis and little bit of pulmonary infiltration?
sir, conservative management.
Okay, so what is conservative management?
Sir, as previously stated, IV bore cannula, oxygen support, bed
Let's
rest.
talk about hemoptysis now specific.
Sir, bronchoscopy.
Done that.
If there is an active bleeding, then cold saline lavage.
There's no active. Mild hemoptysis. Look at the question I'm asking you. I will go through mild, moderate, and severe in a minute. So the question, I just asked you a straightforward question. He's got mild hemoptysis. How are you going to treat the guy?
I like to admit the patient for observation.
Okay.
Start with the and according to the results, like IV antibiotic, blood.
Good. So you want to treat the underlying cause. That is the main thing, isn't it? With mild hemoptysis. So if there is any evidence of infection, you're going to start him on oral antibiotics. Okay. I completely agree with you. You're going to give him some smoking cessation counseling. One of the things you did not ask in the history was a history of smoking. Okay. You did not ask that. Then you did a CT scan and bronchoscopy. Agreed? Okay.
Yes,
there is no resolution. What are you going to do? Or he's got repeated episodes of about 30 ml a day.
Sir, in the same guy, like, sir, suspected.
Yeah, these are the common causes why he will have repeated episodes, because he might have underlying bronchiectasis or he might be a smoker. So basically, when you have mild hemoptysis, all you do is treat the underlying cause. Okay, whatever it may be, you do all the investigations, sputum for AFB, everything, and then you treat whatever is the underlying cause. Okay, that is the principle. Okay, now let's get on to moderate hemoptysis. Tell me, what are the principles of management? In a mild hemoptysis, you may or may not admit the patient. But in a moderate hemoptysis, what do you have to do? You always got to admit the guy.
Hospital admission, oxygen support.
Yeah. Why do you want to admit him?
Sir, he will have a chances of rebleeding, and I have to treat the underlying cause.
What are you going to do to him in the ward? Anything you want to? Are you going to keep him in the ward or HDU, ICU?
So like to keep in ICU.
Maybe not. Yeah. It's only moderate, so maybe you might keep him in a high care unit or something like that. Yeah. Okay, but what you really want to do in a moderate hemoptysis? What will kill the patient?
Rebleeding.
Yeah. So what do you want to observe?
Sir, serial HB monitoring.
Yeah, very good. So one is serial HB monitoring. What else? What monitors will you attach to the guy?
Sir, a pulse oximeter. Sir,
Good.
Drop in saturation.
Good, very good. So you give him oxygen, no? Supplemental oxygen, and you do a serial oxygen monitor. What else will you monitor? Come on, this is routine, man. The guy is there in your ward. You do it 100 times a day. What other attachment will you put him on?
ECG monitor.
Yeah, ECG, but what do you want to look for in ECG?
Beep.
Yeah, it's a cardiovascular monitoring, isn't it? Just pulse and blood pressure is what you want to look at, isn't it? You want to see if the guy is tachycardic or if he's hypotensive. You agree or no?
Yes, sir.
Then serial hemoglobin monitoring. I completely agree with that. Okay. What is the next thing that you want to do? What is the main philosophy of management of hemoptysis as a rule?
Localizing and lateralizing the bleeding. And
very good. Localizing and lateralizing, and more important than that
is the secure of the normal side.
Yeah. So you want to prevent aspiration. That is the first philosophy of management of hemoptysis. That you want to localize the bleeding to the side of the bleeding, and you want to prevent the normal side from getting affected. Okay. So first and foremost, your philosophy is prevent aspiration. Second philosophy is to stop hemorrhage. And the third philosophy is to give definitive treatment to prevent recurrence. Okay. So whenever this guy comes up, if he's moderate hemoptysis, then you will try and monitor him very, very closely, give him the Fowler's position, and then investigate depending on whatever you found. Okay. Now let's get to the next one. Okay. Nikhil, the third principle. What is the management of massive hemoptysis? Sorry, I moved from moderate to massive by mistake. So what else will you do for this massive hemoptysis guy?
Sir, bronchoscopy and...
Yeah. So massive hemoptysis, where will you keep him?
Sir, ICU. Sir, first of all, in massive, I like to stabilize the airway. And
yeah, so you've done ABCDE. Okay. You have to do ABCDE. That is the normal management. So resuscitation is the most important thing. Okay. What's your next position? So I told you the philosophy. This is the philosophy. Okay. Yes, so how will you achieve this philosophy? These three things. Okay. So you put him in the SGICU. You resuscitated him. I agree with you. What else?
Sir, I like to do bronchoscopy and chest X-ray.
Yeah, before that, how do you want to place him? What side down?
If there is a unilateral, if there is a unilateral bleeding, we'll place the patient in lateral decubitus position with the bleeding lung down. If there is a bilateral bleeding, the patient will be placed in Trendelenburg position.
Sir, to know the
which side is down? Just tell me which side is down.
Bleeding side, bleeding lung side will be down.
Bleeding side down. Do you want to suppress a cough reflex or you don't want to suppress cough?
So don't want to suppress.
Cough reflex would be
stop preventive.
Suppressive.
Yeah, but in this patient, to prevent recurrence of bleeding, what do you want to do?
Cough suppression should be
Yeah,
added.
you must do cough suppression. Actually, you'll give him some anti-suppressants, anti-cough things. Okay. What else you want to do?
Sir,
Antibiotics
we'll be
mostly.
treating the antibiotics, steroids.
Good. I agree with you. Antibiotics. Steroids you may or may not give. Depends on what is the pathology. Okay, that is it's open to discussion. Steroids in a massive hemoptysis is open to discussion. Supplemental oxygen you will give. You did tell me about IV access for blood transfusion. I completely agree with you. And then you told me about CT scan and bronchoscopy. Are you okay with this? So far, so good? Everybody happy or not happy? Is it making sense?
Yes, sir.
I'm trying to put flashcards for you to remember how to give an answer in the exam. Okay. So now, what are the interventions available to you in massive hemoptysis, Nikhil?
Sir, to secure the normal side, if patient is not maintaining saturation, I like to do bronchoscopy and endotracheal intubation and isolate the lung.
Okay, so ideally, if you have to intubate this guy, what tube will you use? I'm not talking about this 26-year-old, but if the guy has massive hemoptysis, what will you use? Somebody said double lumen tube. Excellent. If you don't have double lumen tube, then what choices do you have? What are the other choices you have?
Sir, we'll prefer the large size lumen, and we'll turn it 90 degree and ventilate the single side, sir, which is normal.
Yeah, so ventilate the normal side. So that is the second choice you have, you see. So one is double lumen tube. Where will you place the double lumen tube? On the affected side or on the opposite side?
Opposite sides.
Opposite side. Absolutely right. So if you suspect that it is a right-sided bleed, then you must put in a left-sided DL. Yeah, that's important because if you put it on the same side, you cannot ventilate the patient. Yeah, so it's preferable to put it always on the opposite side. Also, if it is a left-sided bleed, putting in a right-sided double lumen tube is a very, very skillful job. And if you don't have an option of an anesthetist who's experienced enough to put in a right-sided DLT, because in a right-sided DLT, you have to place it in such a way that the right upper lobe bronchus doesn't get blocked off. So then you can place it on the left side. But the right side will then be ventilated through the tracheal tube. Did you understand what I just said? Hello?
Yes, sir.
Others, did you understand what I just said? That if it's a right-sided bleed, you will straight away put a left side and forget about it. If it is a left-sided bleed, then if you've got a good anesthetist, you put it onto the right side, but right side placement needs a bit more skill because you have to make sure that the upper lobe is not blocked off, right? Because the right upper lobe comes off very acutely. And there is something called as a Murphy's eye on the right-sided double lumen tube, if you know this fact. So if you can, you should place in a right-sided DLT, but if you cannot, it's safer to place a left-sided DLT rather than block off the right upper lobe. Did you understand this concept or no? And then once you played a left-sided DLT, the ventilation of the right side will come from the tracheal lumen of the double lumen tube rather than from the bronchial lumen, because the bronchial lumen will be blocking off the left side. Yes or no?
Yes.
Okay. So endobronchially, what are the treatments available to you? You've done bronchoscopy and there's massive bleeding happening there. What are the endobronchial strategies available for you?
Sir, cold saline wash.
Yeah, good. What else can you put in the cold saline?
Adrenaline.
Good. I like that. So you put in an adrenaline. How much adrenaline will you put? What is the problem with adrenaline?
Sir, if it gets systematically absorbed, then tachycardia.
It is the highest absorption through the endobronchial mucosa. Okay, that is the reality of adrenaline. So you have to be very, very careful. It's got to be really, really dilute. Normally, I would put 1 drop or 1 ml of 1 in 100,000 in 100 ml of saline, cold saline. Okay, so 1 ml of 1 in 100,000 adrenaline in 100 ml of cold saline. That is the dilution you do. Okay, so very, very highly diluted. What else can you do if you're bronchoscopy? If you're done a bronchoscopy, what else? What other options are available to you for treating massive hemoptysis?
Can do the tamponade by balloon tamponade.
Balloon tamponade. So yeah, you can do balloon tamponade, but better than that, how will you tamponade? One is balloon tamponade. I agree with you. You place a thing, but more. What is available? Do you know what is available to put? How do you put in an endobronchial blocker? What is available to you? So balloon tamponade is possible with an endobronchial blocker. I agree with you. You can put a Fogarty for lobar or segmental bronchi. Anything else is available? Endobronchially, anything else is available? Spigots. Okay. Do you know what's Watanabe spigots?
No.
Okay, Watanabe spigot is like just a plug. Okay, it's a silicone plug, and so you can go into the right main stem or the left main stem and just plug it off, so that there is no spillage of the thing, and the bleeding, whatever happens, will localize to the side that it is bleeding, and nothing will come to the normal side. So it's just like a plug. You know how a drain plug that you have? So Watanabe spigot is just like a drain plug. It's the shape of it's a solid thing which plugs into the right or left main bronchus. Okay. You can also get bronchial spigots which will plug into specific bronchi. So you can go into the right segmental bronchi, you can go into the left and all that. So spigots are available which can be put in. Okay. What else? What are the other options? Let's go through this. What else will you do, Nikhil? In a massive hemoptysis, you've done endobronchial, whatever you can. How will you treat him?
Simultaneously give a blood.
Yeah, you've done that. You've stabilized the guy. You've done everything. You've done a bronchoscopy. You've done a washout. But what is the therapeutic treatment? I mean, it can recur, no? So what is the therapeutic treatment?
I like to do a CT angio with intervention in radiology intervention.
Therapeutic embolization. Okay. So bronchial artery embolization is possible. So endovascular therapy is possible. Yeah. Systemically, anything you will give to the guy? Systemically, will you give anything to the guy?
Ethamsalate, injection ethamsalate.
Tranexamic acid, no? Tranexamic acid. Yeah. Tranexamic acid is the standard. Yeah. Okay. Or you have option of also octreotide or vasopressin. What other things? If it's a malignancy which is causing massive bleed, what can you do? Emergency, what can you do? Endobronchial tumor is causing massive bleed.
So isolate that bronchus.
No, we've done all that. Yeah. Therapy. We have to treat the guy now.
So then the surgery will be planned and resection of the bleeding.
Yeah, but if it's an inoperable thing, what can you do? Emergency, inoperable cancer, bleeding from an endoluminal tumor. You put in the spigot, you put in everything, double lumen tumor is in place. But is there what else can you treat this guy with to stop the bleeding?
Physiological exclusion, which means that we will staple the bronchus.
Surgery is a bit later. Before you cannot. Physiological exclusion is not an operation that you do in cancers involving endobronchial tumors. What do you do? We'll talk about surgery a bit later. Before that, anything else you can give?
Bronchial artery
embolization.
We've done that. We've done pulmonary artery embolization. We've looked at concept of bronchial artery embolization, whatever else. What else can you do? Other treatment modalities available to you. Emergency, you can request them to do something.
Stenting?
Huh?
Stent? No.
You've done endobronchial, whatever you could do, you've done. Give the guy radiotherapy. No, there is something concept called as emergency radiotherapy to stop bleeding. Okay, have you heard of that or no?
No, sir.
Yeah, so very often we actually ask the radiotherapist to take the guy and give him a dose of radiotherapy. Okay, this is emergency radiotherapy for stopping bleeding. What are indications for emergency radiotherapy? All the indications tell me when you can give emergency radiotherapy. One is hemoptysis. What else? Late evening also you take the guy to the radiation oncology and give radiotherapy. What situations will you do that? There's one more indication for emergency radiotherapy, or two actually that I can think of.
Sir, SVC syndrome, sir.
SVC syndrome, yeah, okay, possible, yeah, if it's a radiosensitive tumor. But more important, in an SVC syndrome, I would stent him first before I would go for radiotherapy. But emergency radiotherapy, what are indications? One is hemoptysis. Massive hemoptysis is an indication for emergency radiotherapy. What is the other indication for emergency radiotherapy? I have said this in one of my lectures before. In a lung cancer patient, when will you give emergency radiotherapy? When there is an when there is an impending collapse of a vertebra. Okay, when there's a vertebral metastasis and there's an impending collapse with possibility of paralysis or paraplegia. Okay, then you take him urgently to the radiotherapy and give radiotherapy to reduce the size of the metastasis. Okay, these are the two indications that you do urgent emergency radiotherapy. One is hemoptysis, and the second one is impending compression of spinal cord. So whenever there's an impending compression of spinal cord, it's time to do something urgent. Okay, now we've done that. What is the last option available to you, which you and I can do?
Surgery, sir.
Surgery. Thank you very much. So that's a good one. I like that. Okay. So bronchoscopy, if you do, you must do flexible and rigid bronchoscopy. Yeah. So in a hemoptysis, in a severe hemoptysis, you should usually try and do rigid bronchoscopy rather than just simple flexible bronchoscopy. Okay. All right. So in a flexible bronchoscopy, it's in mild and moderate. We've done all of this. Really quickly, I forgot to ask you, I want to ask you this question. What are the agents available to you endobronchially that you can use? One is you said cold saline and adrenaline wash. What else can you do? Endobronchially, what are the other agents available?
Gel forms.
Okay. Before that, tranexamic acid can be sprayed, okay, into the bronchus. Wherever the bleeding is coming, just inject it with tranexamic acid. The next thing you said is gel foam and thrombin slurry. I agree with you. The third thing I told you was a silicone spigot. Okay, Watanabe spigot can be put in. What is the fourth thing that you can do? You can stent. You told me you can stent it. Okay, so that's another thing. What else can you do? We spoke about thrombin and fibrinogen glue. Any other agents that you know? Endobronchial agents for hemoptysis. Nikhil, come on, man.
Not striking.
Anybody else wants to tell me any other agents that you know?
So recombinant factor 7.
Yeah, recombinant factor 7 can be used endobronchially. Yeah, to cause clotting, and you want to stop the bleeding in that area. What are the other two factors that you can think of?
Cellulose, that is...
Very good. Oxidized regenerated cellulose. And the last one, which is used nowadays quite regularly by the pulmonologist. One more.
It is a glue type.
Yeah, glue. What type of glue?
Name doesn't know.
Yeah, what is the combination? What is the composition of the glue? Cyanoacrylate glue.
Cyanoacrylate.
Okay, cyanoacrylate glue. Yeah. That is very common. What is the precaution you have to take when you use cyanoacrylate glue? Through a flexible bronchoscopy, what is the precaution you have to take?
Sir, in this, that when we place a glue, the instrument should not pull back into a tube.
Absolutely correct. You should never pull back the catheter into the bronchoscope. What will happen?
Sir, because it can damage the working channel.
The glue will block away that channel, okay? So how do you come out? You come out with the catheter outside, okay? Outside. So it should be still outside the bronchoscope, distal to the bronchoscope, and you pull the whole apparatus out.
Yes, sir.
One of the common mistakes that juniors do is they push in the glue and then pull the catheter back through that channel, and then the glue gets stuck onto the channel and it destroys the whole bronchoscopy. It's a very, very expensive mistake. Okay, what else can you do endobronchially?
Sir, we can use laser.
Very good, excellent.
Laser.
Yeah, you can use laser. So common laser that we use is Nd:YAG. Anything else? What are the two other methods available to stop bleeding endobronchially?
Argon plasma laser and
excellent. Argon plasma laser. And what else?
Cauterization.
Simple cauterization. Yeah, simple cauterization. So is it making sense, guys? Are you guys okay or no? So far, so good? Nothing difficult that I'm asking. Huh? Very simple, straightforward questions I'm asking. But this is a very important point that you have to make in the exam. So let's look at the various options. Okay, so this is selective endobronchial intubation. Yeah, so you push the single lumen tube to the opposite side. Yeah, then we spoke about double lumen intubation. Okay, so you push it to the side and then suction out. Use the tracheal one to suction out. So this is the normal side. This is the bleeding side. So you always try to push it to the opposite side. Yeah. The other option is bronchial blockers. We have bronchial blockers. You can put a bronchial blocker. If you don't have experience or you don't have availability of a double lumen tube, you can push in a bronchial blocker. And then last but not the least, we spoke is bronchoscopy. Yeah. Okay. Nikhil.
Yes, sir.
Come back in. What are the agents used for bronchial artery embolization?
So coils.
Okay.
And foam.
So what are they? What foam is it? What is it called as? What foam?
Gel foam.
No, it's polyvinyl alcohol foam, PVA. Okay.
PV.
So that's one. What else you can use?
So coils.
Yeah. And what else?
Gelatin.
Gelatin. You can use gelatin. You can use Giantaco coils. Okay. And all of this will help you to stop the bleeding. So this is the thing. So this is a Giantaco's coil. These are coiling. Can you see that?
Yes,
this
sir.
is a coil which has been used. And if you look carefully in this picture, can you see the flush? Can you see flush? This flush is what you look for. When you see a flush, it means area of bleed. Yeah, this is a flush. This is also a flush. Okay. All right. Okay. So let me ask you, what is the success rate of bronchial artery embolization?
So 70%, but there is a high chance of rebleeding.
So the first time it is quite successful actually. Literature says 90 to 95% they can stop the bleeding. So always the first management should be bronchial artery embolization. Why does it fail? If it fails, why does it fail?
Because there are multiple collaterals.
Yeah, absolutely right. Because of collateralization. Yeah. So that's important. What is the problem with bronchial artery embolization? What are the complications with bronchial artery embolization?
So in the spinal cord has a blood supply through bronchial artery.
Absolutely right. 100% right. You can compromise the spinal artery, okay? You can compromise because that comes off the intercostal and the bronchial arteries. So you might get an embolization into the spinal artery and you might end up with a paraplegia, okay? And the other common complication is contrast allergy and trauma to the vessels, yeah? Okay. What else besides collateralization, what else causes recurrence? What is the other terminology that we use to
Sir, that we have used, it can be canalized.
Yeah,
Again.
recanalization. Absolutely right. You can get recanalization and that can cause recurrence. Okay. All right. So let's talk about surgery. So what are the surgical options available to you for managing hemoptysis?
Sir, lobectomy.
Okay, good.
Uh,
What is the access? What is the access that you would do?
Sir, open thoracotomy.
Okay. And in your case, always say open thoracotomy. Okay. In my hands, I can talk about VATS, but in your hands, you must always say this is an emergency situation. This is for saving life. There's no time to mess around. And we just want to do an open thoracotomy. Okay, good. So you'll do a lobectomy. What else can you do?
Sir, pneumonectomy.
Yeah. Anything less than a lobectomy you want to do?
Wedge resection.
Yeah, you could do a wedge or segmentectomy. If there's an obvious source, like a aspergilloma or something like that, you can do a segmentectomy or a wedge, but rarely you might end up doing a pneumonectomy. But you should try not to do pneumonectomy, yeah, because it doesn't give you good outcomes in real life. Okay, all right. What is bronchial exclusion? Somebody just spoke about hilar exclusion surgery. So Dalival's technique. So what is that lung exclusion? Somebody tell me, explain to me what is Dalival's technique.
Sir, pulmonary artery to that lung and bronchus both are blocked.
What is the access? How do you do Dalival's exclusion technique to get to the hilum?
Sir, I think once I read that we do sternotomy and just place a stapler at a bronchus that we want and staple that
you can do an
bronchus.
anterolateral thoracotomy or a J sternotomy. Yeah, because you want to come in the midline. So you go through the midline. You can either do an anterolateral thoracotomy or you can do a J sternotomy. You know what's a J sternotomy, no? Vertical and a J axis. Yeah, so that you can get to the affected side. And you want to just get into the hilum. Okay, it is always you try and do it intrapericardial or extrapericardial. Both are possible. What do you ligate? What is the main structure that you want to ligate?
Pulmonary artery.
Yeah, you want to ligate the pulmonary artery. What else do you want to ligate?
Bronchus.
Bronchus. Good. And you leave the vein as it is. Okay. So you try and ligate the pulmonary artery, try and ligate the bronchus, but leave the vein as it is so that there is adequate drainage of this. Okay, this is his description. So this is a J sternotomy. Can you see that, a J sternotomy? And you get in right into the hilum straight away. You can go intrapericardial or extrapericardial, and you can do that. What else is available to you? What is a medical pneumonectomy?
Sir, through interventional radiology and bronchoscopy, blocking the pulmonary artery and bronchus.
Yeah, so embolize the pulmonary artery with the coils.
Coils.
Or block of the right main bronchus with a fibrin glue or cyanoacrylate glue. Okay, both are possible.
Sir, both can be done simultaneously.
No. You do one or the other.
One or the.
You don't usually do both. You do one or the other. You may extend it to do the second one, but usually one of the two is what you decide. What else can you do? One more indication for radiotherapy is fungal ball. Okay, if there is a impending bleed from a fungal ball, then there is description in literature of using radiotherapy. What other things have been described in literature? You don't need to know this. Intracavitary sodium and potassium iodide to prevent the bleeding, okay? And endobronchial treatments that are available. What's mortality of hemoptysis? What is the mortality of hemoptysis? So more than 50%, okay? In massive hemoptysis, the mortality is more than 50%, okay? And in cancer as well, 60 to 80%. The moment you get massive hemoptysis, you should be very, very worried that you're dealing with a guy who is likely to die. Okay, is this clear or not clear?
Yes, sir.
Fine, thank you. Well done. Any other questions you want to ask? So what is this? We spoke. Now I'll just go through this again, okay? Just quickly for you. For the exam, just watch the flashcard that's coming, okay? So we spoke about bed rest. We spoke about oxygen. We spoke about antibiotics. We spoke about hemostatic agents. We spoke about sedatives. Sorry, one second. Saiba, I'm actually in a meeting. Can I call you back later? I called you by mistake, actually. Yeah, I'm actually on an online conference. Yeah. Okay. Cheers. Bye. Yeah. So we spoke about that. Sometimes you might have to sedate the patient. We spoke about semi-Fowler's position. We spoke about venous and arterial line. It should be mentioned, all of these, okay? Rigid and flexible bronchoscopy, localization of the source. Make sure if it is suitable for resection, then offer surgery. If it is not suitable for this thing, look for angiography and look for bronchio-arterial embolization. Okay. If it still continues, go to the OR, do flexible or rigid, do rigid bronchoscopy. You have a whole option of endobronchial interventions, but the more important thing is to make sure that the normal side is taken care of. So you do pulmonary separation, and then if it's suitable for resection, you go ahead and do definitive resections. If it is not suitable for definitive resection, do endobronchial interventions. Whatever angiography, BAE, or recurrent hemoptysis in future may need surgery. Okay, is this clear? Hello?
Yes, sir.
This case will come, huh? Definitely. I'm telling you. Definitely hemoptysis cases kept in the exam. Not everybody will get it, but 1 or 2 people will get hemoptysis. So you must know, all of this must be mentioned. What I just showed you should be mentioned, okay? So well done, Nikhil. I thought you did very well today. You answered everything that I asked you. The only thing what I would like to see, Nikhil, is confidence, okay? Answer with more confidence and don't waste time. You know everything. Everything that you told me was correct. There was nothing wrong with what you told me. But what I want to see is that you should answer with confidence and just come 1, 2, 3, 4, 5. Okay?
Yes,
all
sir.
Right. Thank you very much, guys.
Thank you. Sir,
okay. Yeah, go on. Keep talking.
Sir, is there any guidelines or something we have to mention?
No, there is unfortunately no guidelines available for management of hemoptysis. So that is one of the problems. Okay. Yes, all right. So do we have people who have given the exam? Do we have anybody who gave the exam this time?
Yes, sir. Kamran here, sir.
Hi, Kamran. Thank you.
Hello,
Thank you
sir.
for
Good
coming.
evening, sir.
Hi, good evening. So, Kamran, I am sorry to bother you, but
No,
I think it would help us if you share your experience with us. Okay? Is that okay with you?
Yeah, definitely.
So, we want to know from you, number one, first is how was the exam? Did you think that the exam was difficult or did you think the exam was okay?
So the first part was pretty okay.
Put on your camera because we want to see you.
Oh, okay.
If that's okay. If you're decently dressed, then put on the camera.
Fine, sir. Yeah.
Okay. Thank you for coming on, Kamran. Tell me. So share your experience with it.
Yeah.
The first question is, was the exam difficult? Did you feel this was a difficult exam?
If difficult, but you need to practice lots of MCQs because the answer, when you read the question, you know the answer, like what he's trying to ask you. But when you read the options, it's not like directly pointing out. So you have to relate all the concepts and everything.
So if you're a cardiac trainee, do you think you had difficulty in thoracic? And if you are a thoracic trainee, do you think you had difficulty in cardiac? Because you don't have enough clinical exposure?
Yes, sir, definitely. Being a cardiac, like my thoracic exposure is very less until I actually attended your lectures. After that, truly speaking, thinking it was amazing, sir. Really amazing. Everything like after your lectures and all the notes, it made it much easier. Thoracic part.
So is it different from doing your MCH exam?
Yes, sir.
So what was the difference between MCH, DNB, and FRCS exam?
So FRCS is, I feel it's more towards the all guidelines.
Good.
Like for example, sir, I'll just like the way you were like forcing like on EBUS, like we had that lecture before mediastinoscopy, you have to do. So we had like 2 questions and they have put the scenarios and options were all like same. What you said, like mediastinoscopy and EBUS, everything, and then it just pops out like, okay, it's guideline. You have to mark it. Experience is okay, but you have to follow the guidelines.
You have to follow the guidelines. Actually, that's the best way to learn, because particularly if you're not experienced with thoracic surgery and you're a predominantly cardiac person,
it's very difficult.
If you've never seen a thoracic patient, it's very difficult. So the best
very difficult. You cannot
study
think
is to follow the guidelines. That's the reality, actually. And I kept stressing all through that, you have to follow the guidelines. In terms of training for the exam, Kamran, how long do you think, if somebody wants to if he makes a decision today to take the FRCS exam, how long do you think he should take before he gives the exam?
That depends upon like how nicely he has read the textbook at least once, like because it contains cardiac, pediatric, and thoracic also. So at least you should know the. After you have read,
how
then
long
you have
do you
notes.
Think he should take to prepare? Realistic, okay. Average guy.
Yeah.
I'm not talking about super intelligent, but average person. How long?
So
do you
like
think?
After passing DNP or like while after passing, then DNP, I think if you have a good exposure, then at least like a year. I will not say 6 months because it's you have to get the rhythm and the guidelines in your head.
I actually agree with you. I actually agree with you. I think by the time you take a decision and you put in the application and things like that, and because it's a lot of expense as well, isn't it? It's not a cheap exam, definitely. So it's an expensive exam. So I think you should always, whenever there is a point that you start to think that I want to do FRCS, then you should do it 1 year down the road. Yeah. You should take part A 1 year down the road. Right, because the first 6 months go even before you realize it, 6 months are gone.
Right.
And then that is the point where you start really studying. How did you study, Kamran? What sort of notes and things you made, flashcards and things like that? Do you want to just share with us?
Yeah, sure, sir. Sir, like I started like previously, like I followed Sebastian for this, but then I realized it's you cannot complete and you cannot keep everything in a head. You have to sort it out to like narrow angle, but still have a broader vision. And then
so you suggest that reading the smaller books are better than reading a detailed textbook, right?
Yes, sir. Yes, definitely.
Breadth of knowledge is more important than depth of knowledge.
As you said, actually, yeah. As you said, every topic was touched. Every topic was touched.
Yeah. So you
it's
must
not
know
difficult if you know the topic.
Everything. Yeah. You must know a little bit about everything rather than too much about some things and not read another thing. You cannot go to the exam without having read a topic. Yes, because it will turn up like a simple thing like clinical audit turned up. And international people don't actually read clinical audit ever in their education portfolio. So
right.
Clinical audit comes up, and then you guys had cancer drugs. I mean, a lot of people struggled with cancer drugs because they never read about the cancer drugs.
So the options, like 15 options, like I think 3 or 4 answers are right, but
sure,
it's difficult to choose the best one.
No, that's all right. But the point is, if you've read it, then at least you will know 4 options, and then you can try and work it out. What could be the most likely answer? But I think breadth of knowledge is more important. I completely agree with you.
Right. Sir.
What sort of notes did you make, Kamran?
Sir, this Naren Murjani, this two, and So definitely I have watched most of your lectures twice, and as you started guiding us for the 200 pages notebook. I have made it got three. So three 300 pages, all
I can tell you one
notes
thing.
and yeah.
Nikhil has got 6 of them.
Impressive.
three for thoracic surgery and 3 for life.
Nice.
Okay. Anything else you want to tell the other guys on the thing? The reason why I'm asking you these questions is because we are recording this, and we can put it out there for other people who are deciding to do the FRCS exam. So anything else that comes to your mind that you want to share with people?
So practicing MCQs is very important, sir.
Where did you practice MCQs from?
So I had this 200 best SBA notebook.
Yeah. This
and
Shehzad,
one is yes, sir. And 2000 MCQs from that cardiothoracic review book.
Yeah, TSRA.
Yeah, TSRA.
I think Ali just said, Dr. Ahmed said the CSATs. Did you guys read CSATs? Did everybody read CSATs? Why don't you switch on your phone, Dr. Ali Hanif, and just tell us about CSATs. What was your experience with CSATs?
My experience for CSAT was good explanation, but unfortunately I backed off last week. I did not appear.
Yeah, but reading CSATs, what was your experience?
The explanations in CSATs are excellent. They give you all the details. I think the explanation, not by answering one question, the explanation basically gives you details for so many scenarios.
Sure. So I'll share you my experience. Somebody who has been reading CSATs from 8 to 13, 14, I think now. I have read all of them. And I have always felt that CSATs are much, much more detailed. You don't need that much detail for the FRCS exam. CSAT works very well for the American boards. But I think CSATs is a bit of an overkill for FRCS exams. But if you've got CSATs, you must read them. They are very, very good. Excellent notes, but really detailed, very, very detailed. And, sometimes the CSAT MCQs are very difficult to answer, even for experienced clinicians like me. And the reason why I have been doing all these CSATs is for revalidation. Because if you've done the CSATs, then you can put it forward to the medical council as a revalidation tool. In the US, all surgeons have to do, cardiothoracic surgeons have to pass the CSATs to show that you're revalidating. Good. Kamran, can I ask you to try and remember as many MCQs and write them down? Or at least the topics that were covered? And share it with us on Thoracic Gurus. I'll try and accumulate everything together for you guys. And I'll put it out there for youngsters so that, it was an online exam, wasn't it for you?
Yes.
It was one. Was it easy to do it online or was it difficult? Did you find working on the
simple
computer?
software. Yeah, it's a simple software.
And did you have to go into the center or did you do it from home?
No, center, sir. Not home.
You had to go to the center and they logged you in.
Yes, right.
Okay, good. Anybody else has anything else to share with us?
Sir, is there a repetitions of the questions from past years, or that was a new session although?
Kamran, do you want to answer him? I will tell him in a minute, but do you want to give your experience?
I don't think so, sir. They don't repeat. The topic will be repeated, but the questions will be different. The topic will be same.
Yeah, sure. So what happens is the Royal College of Surgeons every year, all the senior people around are requested to submit MCQs. So we all submit MCQs, and there is a committee which actually looks at the MCQs, and they will get the final year medical student and the first and second year residents to do the exam, a mock exam. And all MCQs are graded on the basis of that. And so a lot of the MCQs get rejected. And they only have specific MCQs which have specific answers and which are easily answerable by the trainees. The level of the FRCS exam is year one consultant. I've said this before. So we want to just make sure that you are safe to be a year one consultant. That's all we want to make sure. To be honest, in the UK, most people who give FRCS, I'm talking about the UK trainee, okay? I'm not talking about overseas candidates. But UK trainee, there is a huge, if you go and meet the trainees, you'll find these people, when they come out of the exam, they write down all the MCQs. So there is like a bank which gets circulated all around. The question never gets repeated, but the type of question you can practice. So in the UK, a lot of residents may have these banks of MCQs, but the question never gets repeated, but the type of question may be the same. Do you understand? So the topic may be the same, the type of question may be the same. So like in a tag, if you want to repeat a tag, the question will be the same, because how many questions can you ask on tag? There is only certain things that you can ask on a tag. So if you've done that MCQ before, at least you will go back and read the topic. So that is why it's important to practice the MCQs, because you understand what is the type of question that is asked. The most important thing is to think. The thinking is different in UK. How we approach a patient, what is our first line? Like he said, EBUS or mediastinoscopy. And most of us are trained to think guidelines. So you must read the guidelines, even for cardiac surgery, you must read the guidelines in detail. Either the American guidelines, European guidelines, but always the answer is from the guidelines, never from outside the guidelines. Yeah? Okay. Thank you very much. Any way we can change our teaching to make it better? And this is open to everybody. Everybody can ask, give me suggestions. And this is a genuine question from me to all our friends.
I think interactive sessions are very fruitful and very beneficial for everybody.
So what we are doing now, is that what you mean by interactive session?
Absolutely.
What we just did? Okay.
Yes, absolutely. Yes.
Okay. I mean, the theory we have covered more or less. So now we are into an interactive things. So I agree with you. Any way I can change the interactive session, Ali?
Probably, I think you can send us some MCQs to solve, and then we'll and get back to you on discussion. That would be a better exercise, I believe.
Yeah, my only problem with sharing MCQs is that because I'm on the board of a few things, when it comes from me, it's not right. It's not, they will raise an objection to that, because I'm also setting some papers for other boards as well. So that's why I find it difficult to share MCQs. But because I've read a lot of these MCQs, when I'm teaching you, I point out, every time when I'm doing a slide, I will point out to you that this is an MCQ. Please remember, that is the way I can help you with MCQs. But if I put out MCQs, it's very difficult for me. It's a touch and go situation, particularly with the Royal Colleges and the Asian Board as well. So that's the only issue that I have with sharing MCQs and sharing PDFs. But yeah, if we can help you, we'll try and help you. Anything else? Any way we can change this interactive teaching? Go ahead and share, guys. Yes or no?
Sir, it's going fine, sir. We can go with the same way, sir.
Is it going fine? Okay, good. I'm happy. In cardiac, can we do anything more in cardiac? Have we covered all the cardiac topics?
TE, if we can echo and TE.
Okay, TE and echo. All right. What else?
Like there were a few questions. They asked, like, if you are calculating aortic area, then which view you will calculate the
Sure.
Yeah, and they have to use the formula. Yeah.
So TE and echo. Okay, I'll look into that. I'll try and get you a speaker for that. What else? We didn't cover drugs and pharmacology, didn't we? I mean, but I don't know how doing a lecture on drug and pharmacology can help you with MCQs, but I'll look into that. But drugs,
Sir, cancer drugs,
cancer drugs, okay. But we covered immunology, immunodrugs. We did cover a little bit about immunodrugs, but okay, we'll look into that, cancer drugs and immunodrugs. Okay, what else? Any other topic? There's a lot of basic physiology. I'm not sure if you guys are strong in basic physiology. ABGs and stuff like that, and
that's
monitoring.
Really vital. That's really vital, and we need to. I think we need your guidance in that. The basic physiology at the cardiac level, even the pharmacology.
Okay. Yeah. I have tried to take some lectures. Have they helped you? The basics lectures? I did an ECG session and I did an IBP session. Did that help?
Yes, definitely, sir. Helped a lot.
Okay, so basic physiology. We can do that. We can do that. And what else? Anything else? Any other suggestions you want to make, or shall we call it a day?